So now we discuss the different approaches to imaging the four chambers, so the apical and the subcostal. And now we're going to talk about the morphology of the heart, specifically about chamber morphology. So it's important to know, we all know the right ventricle sits the most anterior and left atrium is most posterior chamber in normal anatomy. So we have to remember that's not always the case with congenital heart disease. There are different anatomic markers that we can use to prove which chamber is which. And so we're gonna jump right into that right atrium. So let's talk about that morphologic anatomy of the right atrium. So the SVC and the IVC drain into the right atrium. And then we have that IVC has the Eustachian valve, which you can see at times with the four-chamber view. And we also have the coronary sinus opening into that right atrium. And we have a right atrial appendage, sorry, which is a broad-based and triangular in nature. And that is so important because a lot of these things we're not seeing in the four-chamber view. So the appendage is something that we can use as our marker that we can, use to assess the morphology.
Yeah, and that's really important. That's a great point because most people will say, you cannot, you can't say there's an IVC draining to this right-sided atrium, so it's a right atrium. That's not always the case. But almost always, the right atrial appendages, those are uniformly known as the most reliable ways to demonstrate the morphology of that atrium. And as Amy said, the right atrial appendage is very distinct in shape, and it's very broad-based triangular, and as it's a little more anterior, and you'll see a little bit of muscular trabeculation near the right atrial appendage. And that's something that you can see from a four-chamber view. And again, some of these points we're talking about, we're not going to see, obviously, the SVC, IVC entering the right atrium in a typical four-chamber view. But as you put this together as part of your comprehensive exam, those are great anatomic markers to look for as you go forward.
All right, and then the left atrium. So like we said, it's the most posterior chamber closest to the spine in normal anatomy. We have the foraminal flap opening into that left atrium. We have the pulmonary veins entering that left atrium. The coronary sinus can be seen here if you angle the transducer slightly inferior. And then it also has an atrial appendage, which is finger-like and narrow. So it has a different appearance from the right.
Yep.
All right. Okay, and this is pointing to that flap, that foraminal flap. So we just see how it's opening up into that left atrium, which is normal. And then here we're looking at that atrial septum, and we see a hole. So we know that is the foraminal valley. It is open in this picture, but we still see septum. So that red arrow is pointing to that septum primum, and the blue arrow is pointing to the septum secundum.
Obviously, atrial septal defects are one of the most difficult diagnoses to either confirm, or rule out in the fetus, because we have that natural opening there, and that flap of the fossa ovalis can be so thin and so difficult to see. So, but it is key, as Amy said, make sure that we have intact primum and intact septum secundum there.
All right, and then we see those pulmonary veins, the right and the left, and if you are having trouble getting those, Power Doppler is a great application to use since it picks up slow flow. That can really help you if you're having trouble getting the pulmonary veins in grayscale.
Yeah, that's a great point because, we know in fetal physiology, less than 10% of the cardiac output actually comes back via the pulmonary veins. So very little amount of blood and very low velocity. So power angio or power Doppler is a great tool.
Okay. Yeah, it can be very helpful. All right, so let's look at the right ventricle. It's the most anterior chamber to the chest wall with normal anatomy. It has coarse walls that are trabecular in nature. Something that it's probably most well known for is the moderator band, which is easily distinguishable because of that thick wall. And then we also have the tricuspid valve. It's a 3-leaflet valve, and it's apically displaced in relation to the mitral valve. And then we have papillary muscles that attach to the septum. So they're septophilic. And this is a beautiful cine clip pointing towards that right ventricle and showing that moderator band. Yeah, that's nice. All right, so let's talk about the left ventricle. It is smooth-walled and conical in shape. It has the mitral valve, which is a 2-leaflet valve, and 2 papillary muscles that are evenly spaced, which are septophobic. So there's no attachment to the septum in the left ventricle with those papillary muscles.
Yeah, they are so scared of that septum. I mean, it's just, they can't even attach, so.
Septophobic. And then one other thing that we just wanted to mention about the left ventricle, most reported EIFs are seen in the left ventricle.
I'm glad you brought that up. That's a good point. Yeah. And associated with the papillary muscle configuration.
Yes.
In the LV.
And here is a beautiful clip showing that smooth wall of the septum. So we have no attachments there, and you can really just see that wall is so smooth, the septal surface.
Yep. And it's interesting the way, I mean, it's just, it has never ceased to amaze me the way the heart is put together. The posterior wall of the left ventricle, it is trabeculated as well, but it's really fine trabeculation as opposed to over on the right. You have much more coarse trabecular muscle layout, much more of kind of muscle bundles in that RV. But as Amy said, one of the most characteristic distinguishing facts is the smooth septal configuration here on the left ventricular side.
Okay. Yeah. All right. Color Doppler is essential. So there are so many benefits of us using color Doppler. We can assess the septum, evaluate color flow across the AV valves. We can demonstrate the direction of flow, presence of flow. We can show turbulent flow, regurgitation. It's definitely essential that we use it when assessing the heart.
Yeah, and the thing I would add here too, is the value of the cine loop, because I may be scanning, I may be assessing in this image for atrioventricular valve regurgitation. I may be looking at inflow. Does it look laminar and smooth? Which both the mitral and tricuspid looks great. There is a tiny, tiny, tiny whiff. If you squint your eyes just right, you'll see just a trace of tricuspid valve insufficiency. Depending on what you're scanning this patient for, that may or may not be of any real consequence. But we're focused on this. Your interpreting physician might be looking at the ventricular septum, and they might see a little apical muscular VSD, or they might be able to say, hey, look at this right pulmonary vein, beautifully demonstrated flowing into the left atrium. So that's the value in the cine loop, is you get a lot of different ancillary information, even if you're not looking specifically at that point of interest.
Yes. And like you said before too, it just gives another set of eyes a chance to look,
Exactly.
Yeah.
Yep.
All right, so pulse wave Doppler, we can do we can assess the inflows and outflows with pulse wave, the cardiac rate and rhythm. This is where I like to get it, you know, and then, yeah.
You know, the nice thing about pulse Doppler to me, Amy, is,
Yeah.
you know, color Doppler is great because we can see things and quantitatively assess things. Pulse Doppler allows us to really quantitatively assess things. We can look at specific flow velocities. We can look at gradients. We can, like you said, assess cardiac rate and rhythm, PR intervals. I mean, we can really dive in a little deeper with the pulse wave. So again, it's just, you've got your toolbox, and these are all tools that are going to help you better assess the heart.
Yes. All right, and this is an example of that. Looking at that AV Synchrony with pulse wave. And this is how I like to do it.
And me too. I agree 100%. I mean, I think, you know, talking to Amy, this is such a nice, easy way to see. In this case, you're looking at mitral valve inflow above the baseline, followed by a ventricular outflow through the left ventricular outflow tract. And so we can stop this, we can measure intervals, but even just looking at this, you can tell this is 1-to-1 AV Synchrony. So it's a super fast, and that's the whole thing, right? You guys have such a tremendous task because you're not just looking at the heart, you're looking at the heart and a lot of other things. So you are asked to see more and more patients in a shorter and shorter time. And so spectral Doppler assessment of cardiac rate and rhythm, I think, is a very efficient and effective way of doing it.
Yes, absolutely. Thank you, Jason. All right, so we're going to look at M mode, and since M mode has been around for a while, I'm going to let Jason take this slide.
Yeah, just for all of you guys tuned in, I did not want this slide in because this was Amy's way of making an old man joke about me. You know, M mode is interesting because really echocardiography started with, well, I shouldn't say started, but M mode was used very early on as the diagnostic method in ultrasound. And so people use M mode have used M mode for rate and rhythm assessments for a long time, specifically because M mode has the most sensitive temporal resolution, much more than 2D, certainly before our ultrasound machines got better and our imaging became so much cleaner. And so the premise is pretty simple. Our transducer is up here, and so we drop a single beam down through we try to catch the atrial wall and then a ventricular wall. And by doing that, if you look down on this lower right-hand side, you can clearly see the atrial contraction above, followed by the ventricular contraction below. And once we have that, we can easily measure that. And you see on this one, you have an atrial rate of 147 beats per minute, married by a ventricular rate of 147 beats per minute. So a lot of people still use M mode. I still use it sometimes, although I'm coming into the new era of, you know, pulse wave analysis. So
catching up.
But thank you, Amy, for making me realize my age. And we're going to move on quickly.
Okay. Oh, wait, I want to say one more thing about M mode.
Of course.
I just want to remind everyone to be mindful of ALARA as low as reasonably achievable. So with M mode, you know, if baby's less than 14 weeks, I use M mode for heart rate, just for safety. Yeah.
Good point.
Yeah. And then here we have our 4-chamber checklist. So this is kind of like that mental checklist that we have in our heads. You know, we just showed that 4-chamber is just one of many cardiac views that we do in an anatomical survey. And we're not just taking a still image of what views are required, but really evaluating the structure of the heart and all of these components. So it's good to kind of have this checklist in your head.
Yeah, it's a tremendous amount of information. You know, sometimes we think, okay, are there 4 chambers? Check, let's move on. But within that one view, as Amy said, there's so much information that you can extract from that one imaging view. And so it's really, really important. It's a great kind of I've always seen the 4-chamber as kind of an anchor view. You know, with a good 4-chamber view, you can glean a lot of information about that heart.
Yes. And then with that said, I just want to say, look at all the things we're looking for in that 4-chamber. And despite that, we can still have a normal 4-chamber view and have abnormalities. So, and these are all examples of that. So it's just so important that we add those outflow tracks, see the crossing, and then add that 3-vessel view.
Yep.
It'll just really help increase detection rates.